Thank you so much, Dr. Megur, for making me part of this extraordinary course. And I think everyone will agree that it will be probably impossible to find better videos than what he and his team can show. So thank you so much for the excellent videos and the excellent teaching pearls. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. I think any of us who operate are going to encounter this situation where the capsule ruptures and the vitreous is staring at your face. So the most important point, irrespective of what you do later, is to prevent this from enlarging further, which means inject from the second port a dispersive viscoelastic. And here, like Dr. Megur mentioned, why is dispersive important? Because dispersive will stay there. It will tamponade at the area. Unlike a cohesive viscoelastic, which comes out easily in one bolus immediately. So inject a viscoelastic, and however experienced you may be, there is no other sign of identifying vitreous except for using diluted preservative-free triamcin alone. Like in this case, if you'll notice here, everything, all of the clinical signs that we have been taught of are perfect. The pupil is round in shape, there's no distortion of the pupil margin, no peaking, and still there was a vitreous strand which was extending from the PCR right up to the side port incision. So do not swipe the wounds, but always look for the presence of vitreous by injecting diluted triamcin alone. And the next question is, when do I do vitrectomy? It's a very simple answer. Whenever you notice vitreous disturbance, it could be right at the beginning of surgery, it could be with 3/4 of the nucleus inside, it could be just before IOL, or it could be with cortex inside. So until you tackle the vitreous, once you identify it, do not move on to the next step. And we'll come to why is that important. The goal of vitrectomy is, we need to understand the goal. The goal is to prevent acute intraoperative vitreoretinal traction. Because what the traction that we are going to cause intraoperatively is going to determine the long-term health of the eye. We may satisfy our ego that, I prevented it from dropping, I could put the lens in the bag, but the patient develops RD 3 months later or glaucoma 4 months later. So it's the intraoperative vitreoretinal traction that you do during surgery that is going to determine the long-term fate of the eye. So there should never be a trend, we don't want to salvage the nucleus at any cost. This is a very basic but very nice animation to show that you have an anterior capsule split in this case, and the nucleus is showing, is just gone behind the anterior posterior capsular tear, and you think it's just there. Let me go and grab it, let me go and do something about it and get it there. What we don't realize is, by making these maneuvers, the traction that we are causing at the vitreous base as well as at the macula. And these are the things that lead to giant retinal tears, cystoid macular edemas post-operatively. So best is, if the nucleus drops, the simplest technique is what we describe as the bye-bye technique. Let it drop, do a good thorough anterior cleaning of the anterior vitreous, and let the vitreoretinal colleague take care of the dropped nucleus. This is a video I borrowed from my vitreoretinal colleague at our institute, showing a subluxated, dislocated cataract, and notice the amount of vitreous adhesions that are there around it. This is something that we don't normally see with our naked eye, and we just feel that there's just one fragment, let me grab it. So it's very important that you remove the traction or the attachments of the vitreous before you handle any fragment or anything else. The secondary goals of vitrectomy are to prevent further enlargement of the PCR, do an adequate vitreous removal, and provide a symmetrical uniform scaffold as much as possible for an IOL implantation either in the bag or in the sulcus. Irrespective of the type of vitrectomy we do, limbal, pars plana, this is the principle which we must always follow. Never perform dry vitrectomy. So you must always have fluid coming in either from the limbal route or the pars plana route, and do not, and give up the habit of using sponge to identify the vitreous and cut with the scissors. When you apply a sponge, it causes tremendous traction from where the vitreous is coming from the vitreous base. So these are two important principles to keep in mind. And always do bimanual vitrectomy, which means separate the irrigation from the vitrector. So even if you have a machine which has a coaxial irrigation aspiration for cortex removal, for vitrectomy you must have a bimanual system, which is the irrigation and the cutter should be separate. Now, which approach to choose, limbal or pars plana? I think each has an advantage and disadvantage one over the other. But the take-home message, whatever technique you use, is adequate vitreous removal has to be done, whatever technique you are comfortable with. The advantage of a limbal approach is that it's something that we are all used to, working from the limbal area through our side ports, and that is how we have been, that is how we have learned, all of us as cataract surgeons. The major limitation of limbal vitrectomy is that when you drag from above, you are dragging a larger amount of vitreous body from coming, and generally the posterior capsular tear enlarges. But I really appreciate Dr. Megu's previous presentation showing tricks on how to prevent that from occurring even from the limbal route. This is a high-speed photography to show the same, that when you are doing limbal vitrectomy, here the port is facing up, there is significant drag on the vitreous, and you'll see the margins of the capsular tear enlarge. But even if you turn your face down through the posterior capsular tear, you are dragging on a much larger base or a larger chunk of vitreous, which causes a lot of turbulence and quite often causes turbulence at the capsular tear margin. Coming to the pars plana approach, we always find it intimidating that we are not retinal surgeons, how can we enter through the pars plana? And do I need separate machines, separate instruments, so on and so forth? So fortunately, not much is needed. The major advantage is that because we are draining it from where it is actually coming from, we are actually attacking a much smaller amount of vitreous than or what is only required, and therefore the chances of enlargement of the PCR are lesser than a limbal approach. Notice this again, the irrigation is through the limbal approach, the vitrector is through the pars plana, and very minimal turbulence occurring at the edges of the posterior capsular tear. Like Dr. Megur showed very nicely how to approach it face down, the only limitation with the limbal is in spite of changing hands, the ergonomic access is generally limited, and therefore there are chances of leaving behind unequal pockets of vitreous around the area of the PCR, which may lead to some tilt of the IOL in the post-operative period. Compare that to the pars plana approach, where the ergonomic access is much easier. So you're just moving your right hand, and remember it's only 3.5 millimeters away from where you are already working. So it should not be too much of a big deal. How do we approach it, and how do we start doing a pars plana vitrectomy? The first thing to know is where to make the entry, and for that basic anatomy is important to know. And generally for an adult eye, somewhere in the region of 3 to 4 millimeters is the area of the pars plana. It varies, of course, based on the axial length, based on the corneal diameter, so on and so forth. But generally for an healthy adult normal eye, it's somewhere between 3 to 4 millimeters from the limbus. And generally we use a standard cutoff of 3.5 millimeters from the limbus. So you can use a caliper to measure 3.5 millimeters. Mark it from the limbus, and what we typically like to do is to do a single plane entry but make two incisions, which means I'm first lifting up the conjunctiva so that my conjunctival entry is different from my scleral entry. So when I bring out my trocar, the two should not coincide, and therefore sealing will be better. So I'm lifting up the conjunctiva, just making a subconjunctival entry, then turning the trocar down, and the direction has to be as if you want to go and hit the optic nerve, which means you want to go vertical and as if you want to go and hit the optic nerve. That will never happen. But if you try to turn it sideways, you may end up going through the posterior capsule. So this is how you generally make it. Now with the newer generation trocars, you have markings even on top of the trocar, so you need not necessarily have to even do a caliper marking. But what's most important is that you want to make sure that the chamber is adequately formed before making the pars plana entry, because if it is not, it can collapse. Like this eye, fortunately, we did not require to take any sutures before making the pars plana entry. But in most eyes, I would certainly recommend taking a suture at the main incision, even if it may be just a 2.2 millimeter incision. Just take a suture so that if the chamber is formed properly, it will be easier to make a pars plana entry. Another important point is when you remove the trocar, there is a tendency of a wick of vitreous coming in the area of the trocar. So you must be ready with the counter traction. So immediately as soon as you remove the trocar, this is what retinal surgeons recommend, a blunt instrument to just tampon at the area from where you have removed the trocar and massage it so that there is no strand of vitreous that is coming out. Now you need know, if you don't have access to trocar, if you're scared of using a trocar, simplest is to use your lance knife or your same MVR knife or your side port knife. You generally have to do a conjunctival peritomy because doing transconjunctival will lead to ballooning of the conjunctiva as soon as you go in and out of the incision. So do a conjunctival peritomy and then use the same lance knife to make a 3.5 millimeter incision 3 to 3.5 millimeter away from the limbus. The only drawback would be that you need to suture this wound after you've finished up all the vitrectomy, because this would typically be a 20 gauge vitrector which would not self seal. So you can easily suture the conjunctiva as well as the port. What gauge of vitrector? I think smaller is better, but most cataract machines are still equipped only with the 23 gauge systems. So we don't get cataract machine cutters more than 23 as of now, but I'm sure it will increase with time. So smaller is better, and 23 and beyond is usually self-sealing. What are the optimal parameters for pars plana vitrectomy? And that is, I think, it was very nicely highlighted by Dr. Megur previously. That one is you want to keep your irrigation low, which means either the bottle height or the intraocular pressure low, somewhere in the range of 20 to 30 intraocular pressure. A very low flow rate. So I'm keeping a flow rate of only 15 cc. So I don't want too much of attraction coming up. And a vacuum appropriate, depending on if you have had to use too much of viscoelastic injection, you may need initially a higher vacuum, but generally a vacuum of around 250-300 is enough. And go for the maximum cut rate that is there on your machine. It could be 1500, it could be 2000, 2500, whatever it is. Here in this case it's 4000, now with the upgraded software it's 5000. But whatever the maximum cut rate that your cutter offers or your machine offers, put that as the default setting. So just a couple of cases to highlight the role of pars plana.
Yeah. One more minute.
Yeah, sure. So this is a case where 3/4 of the nucleus is inside the capsular bag, but I've noticed a large PCR. So whenever you notice PCR, you must confirm whether vitreous is present or not, and sure enough, it was present. And therefore, we need to tackle it before I look to tackle the rest of the 3/4 of the nucleus. A good anesthetist will always help. They may bump up the, and look at this pars plana drained nicely. That vitreous that was there, it got sucked in beautifully through this PCR that is there without causing an even millimeter of turbulence in the area of the PCR. And now since we have cut off the connection between the anterior and the posterior compartments, we can go ahead without the fear of dropping this nucleus with phacoemulsification with low parameters, low flow rate and low bottle height. Because this tear was extending up to the equator, the choice of IOL, of course, was a 3-piece IOL with optic capture. Most of these patients do very well post-operatively. And even in the end, make sure that make sure that there is no vitreous disturbance in the end. So I'd like to end here, and the most important take-home message that I would like to share is, irrespective of whatever technique you are comfortable with, doesn't matter, limbal, pars plana, one may have a slight advantage over the other. The take-home message should be, vitreous needs to be tackled. It needs to be tackled adequately from this route or that route before going on to the next step. And diluted triamcinolone acetonide is something that all of us should have as a backup in our ORs so that the assistants don't have to scramble to find it. Thank you once again for the patient listening.
Thank you, Shail, for the extraordinary presentation. Very nice. Thank you for teaching us all the basic principles of pars plana approach.